Welcome, everyone, to this program titled Familial Chylomicron Syndrome, Breaking Barriers in Treatment. I'm Dr. Erin Michos. I'm a professor in medicine and cardiology at Johns Hopkins University, and I'm really excited to be here today with my colleague, Dr. Ira Goldberg, who is professor of medicine in the Division of Endocrinology, Diabetes, and Metabolism at NYU School of Medicine. And I'm especially excited because this is FCS Awareness Day is approaching this Friday, the first Friday of November. So welcome, Ira.
Oh, glad to be here.
So first, I'm going to start with a case for you to think about. So this was a 45-year-old man who's had recurrent pancreatitis who's been referred to our lipid clinic for recurrent severe hypertriglyceridemia-induced pancreatitis. And he's seen many clinicians over the past 4 years. His history is that at age 15 in 1994, he was found to have triglycerides above 1,000. And then at age 18, he developed his first episode of pancreatitis when his triglycerides were above 2,000. And then between 2000 and 2005, he had 3 episodes of pancreatitis. He was on a low-fat diet, and he actually did well for another 15 years until he had another episode of pancreatitis, his 4th episode at that point. And then for the next 4 years, between 2020 and 2024, he had 3 more episodes of hypertriglyceridemia-associated pancreatitis requiring hospitalization. And of course, along the way, in addition to low-fat diet, he's been treated with fibrate and atorvastatin, but it didn't really help his triglycerides that much. They've remained between 1,500 to 2,000. His family history isn't that remarkable. His parents had longevity. They only had mildly elevated triglycerides. His siblings, only one had severe hypertriglycerides, but only in the 400 to 600 range, not in the thousands like him. And he has one daughter who has mild triglyceride elevation. Of note, he's lean appearing. His BMI is only 18. He didn't have any eruptive xanthomas on exam, but he had positive lipemic retinalis. And for his lab results, his total cholesterol is 170 milligrams per deciliter. Triglycerides at this point on his low-fat diet, atorvastatin fenofibrate, is 1,200 milligrams per deciliter. His HDL is low at 11. Couldn't calculate an LDL, but his ApoB 100 level is very low, less than 80 milligrams per deciliter. He doesn't have diabetes. His A1C is 5.2 and his thyroid is normal at 1.7. So tell me, we don't have any genetic tests back yet, but do you think this patient meets the diagnosis of FCS, and what are some of the clinical and laboratory features?
Yeah, so I think he does fit. He has hypertriglyceridemia and pancreatitis at a relatively young age, although many of these patients actually present much earlier, sometimes even as babies when they have a difficulty, drinking mother's milk, or sometimes with formula. And then they sometimes give you a history that they were the one kid who didn't eat ice cream at the birthday party when they were 5 or 7 years old, because they had noticed themselves that when they would eat sort of high fat containing food, they would feel uncomfortable, or perhaps even get some level of pain. Perhaps they even had pancreatitis and they didn't even know about it because it wasn't severe enough. So his presenting the first time at 18, fits with this. I've seen several, especially women, who don't present until college age. In fact, I have 2 FCS patients who presented when they were put on birth control pills when they went to college, neither of whom had a pancreatitis episode before that. He's thin. He doesn't have other kinds of abnormality. He doesn't have diabetes, doesn't have obesity, and has had recurrent pancreatitis episodes, and seems to have been spared from that a little bit when he was really on his diet. I guess the last thing is that the usual medications, fibrates, fish oils, don't look like they work for him. I should say the one thing that's an outlier actually is lipoprotein lipase deficiencies, or those kind of abnormalities. He probably inherited 2 abnormal alleles, right? One from his mother, one from his father. So both his parents are heterozygous, and heterozygosity of lipoprotein lipase, for example, is actually associated with more coronary artery disease. It's like the #2 genetic cause after LDL receptor defects. But, like all coronary disease in all patients, they don't all, fit exactly the rule.
Right. Well, FCS is, rare, and being autosomal recessive, he doesn't, it's typically parents won't have the same severe phenotype because it's autosomal recessive. It affects 1 to 2 people per million worldwide. And as you mentioned, the key, the defect is impaired function of the enzyme lipoprotein lipase. And you highlighted some of the key features on his, labs. He had very high triglyceride levels. Having a ratio of triglycerides triglycerides to total cholesterol ratio greater than 8 is often a diagnostic indicator. Having low ApoB is a diagnostic indicator because the defect in processing triglycerides of exogenous origin is so profound. Chylomicrons are not broken down, and so the minimal chylomicron remnants formed are insufficient substrate for the liver to make the ApoB lipoproteins, VLDL. So what I think is classic in FCS is they'll have paradoxically, low ApoB levels, but very, very high triglyceride levels. And you mentioned the lack of response to, treatment. So typically the mainstay of treatment is the low-fat diet, and it can be really restrictive. Patients with FCS have very unique and specific dietary requirements. Very extreme, restrictive low-fat diet, typically less than 10 to 15% of total daily calories, which is the equivalent of, only 15 to 20 grams of fat a day. And that can be really, really hard to achieve. That's why it's recommended that they work with a registered dietitian, nutritionist who has expertise in FCS. It can be really hard for these individuals to socially, as you mentioned, to eat out with friends and family because of the restricted diet. They can't have any alcohol. It can be very, a very hard diet to follow. But strict diet adherence is essential to prevent pancreatitis. And then because they don't have any functioning LPL, the typical medicines we use to treat high triglyceride, the fibrates, omega-3, niacin, statins, typically have poor response to an FCS because these medicines require, functioning LPL to work. But we have new therapies on the horizon that are approved and emerging. So Ira, why don't you tell us about some advances we have for these patients?
Yeah, so the first thing is really what they should do before we talk about the new therapies.
Mm-hmm.
So it is impressive how some of these patients can do quite well. But that really requires a lot of effort on their part. So I have taken care of 2 women who've had triglyceride levels, mostly averaging 500 to 600, which are almost unheard of levels for this kind of disease. But these are thin young women who eat no fat and who basically are doing 1 to 2 hours of exercise every single day. And the FCS, really becomes a major part of their life. I have other people who can't stay on the diet, and the one adjunct that's used for them is to give them a fat absorption inhibitor called Zenical, or it's sold over the counter as OI, but you could buy it and double the dose. A lot of patients won't take it because you are on this and you have one fatty meal and you get rip-roaring diarrhea. So there are people who take it or don't take it. So now we have several new therapies, and the new therapies are really amazing for these patients. It totally changes their life. It makes them almost normal, they will tell you. And the 2 therapies basically work in a similar manner. They are short oligonucleotide strands that bind to the messenger RNA for a protein called ApoC3. ApoC3 is an inhibitor of lipoprotein lipase, but it also is an inhibitor of liver uptake of probably all triglyceride-rich lipoproteins. So even if you have no LPL and you inhibit the ApoC3, triglyceride levels go down, and they go down amazingly amounts, 70 to 80%. And the incidence of pancreatitis goes down well over 90% in those therapies. So one is called an antisense, which is a mixture of nucleotides, and the other is a silencing RNA. Another one is an RNA that is a total match for a piece of the messenger RNA that makes the ApoC2. And they both block ApoC C3, not C2, C3 production, and they're both extremely effective therapies and are really game changers for people with this disorder.
Yeah. So as you mentioned, olezarsen is the ASO inhibitor of ApoC3, and that is currently FDA approved for use with diet for reducing triglycerides in patients with FCS. And that was based on the BALANCE trial, where patients who had genetically confirmed FCS, olezarsen reduced the mean triglyceride levels by 44%. And although it didn't meet pre-specified hierarchical endpoint, we did see about 88% lower risk of pancreatitis in the BALANCE trial. And then the second one, as you mentioned, is plozasiran. That's the small interfering RNA of ApoC3. It's currently under review by the FDA for approval for treatment of FCS. I think we'll hear later this month. But the submission to the FDA for approval is based on the PALISADE trial, where it reduced triglycerides by 88% in patients who either had genetically confirmed FCS or met clinical criteria by FCS. And there was an 83% reduction in pancreatitis with plozasiran. So this is really exciting because, you know, these patients generally are at lower risk for ASCVD, but their main health threat is pancreatitis, which is an extremely can be morbid disease and be associated with increased risk of mortality. So I'm really excited that we have these agents because there really was, you know, very little we could offer them before other than the low-fat diet, and this has been a game changer for these patients.
Yeah, absolutely, absolutely. So I've had patients in both trials, and I now have patients on both extension trials. And hopefully the companies will continue to supply them because the patients will tell you how much the therapy has changed their lives. So they're not worried every minute about, oh, am I going to eat something and get another episode of pancreatitis?
Yeah, so this disease, you know, has a significant burden for the patients. I mean, we've just talked about the pancreatitis episodes, but many patients with FCS are living with chronic abdominal pain. They have other health issues such as fatigue, brain fog. Often their disease impairs their ability to work because they either have, you know, pancreatitis or chronic abdominal pain. And a lot of people don't understand their disease, so it has social implications. And management and treatment of these patients really requires a multidisciplinary team. So often these patients benefit from involvement from endocrinology, lipidology, gastroenterology for all the pancreatitis issues. We refer sometimes to genetic testing, genetic counseling. I mentioned the role of the registered diet nutritionist and primary care. And multidisciplinary coordinary care can help with a timely, accurate diagnosis and hopefully reduce hospitalizations and improve quality of life for these patients. Because really, the earlier we can recognize and the earlier we can implement therapy, the improved outcomes for these patients.
Yeah. We should probably know two other things, by the way, is that here I am in the Northeast, and so we often want to know whether somebody has a French-Canadian background, which is more likely to have the LPL defects, or Chinese or Asian, which is associated with defects in two other genes that are associated with severe hypertriglyceridemia and FCS. And so we do want to know a little bit about the background. And the other thing about this particular patient, and I saw somebody like this a number of years ago, I note that his BMI is 18, and my patient, like this guy, probably was just afraid to eat.
Yeah. Well, unfortunately, we are out of time. I want to wish everybody a happy FCS day this Friday to help continue promote awareness about this disease. I want to thank everybody for joining us today, and please check out Medscape Severe Hypertriglyceridemia Education Hub to learn more about FCS and the advances we have now in management. Thank you.
Bye-bye, Erin.